Good morning. Welcome everyone, and thanks for being here. I'm Tarek Brown, President and CEO of CICOA Aging and In-Home Solutions, and I'd like to welcome you to our first Envision Lecture of 2020. If you are new to the Envision Lecture Series, you are in good company, because I am too. I started at CICOA in January, and if we were able to meet in person today rather than online, I would love to shake your hand. Instead, we'll have to wave hello. This is our first time hosting the lecture in an online environment, so we'll keep our fingers crossed that the technology works and that everything goes smoothly. If for some reason you get bumped off or get interrupted by a toddler or an Amazon delivery truck, don't worry. We are recording this, so be on the lookout for an email later today with a link to the entire presentation on our website. The Envision Lecture Series is designed to bring to the forefront issues and trends that impact the health and quality of life of the population we serve. Today's topic is timely and one that we haven't heard anything about in the media's coverage of this pandemic. Our theme is Surviving COVID-19, the long-term cognitive and mental health effects on patients and their caregivers. But to tell you more about that and to introduce our guest speaker, let me turn it over to Dustin Ziegler, CICOA's Vice President of Community Programs.
Thank you, Tarek, and welcome everybody to this morning's CICOA Envision Lecture Series featuring Dr. Sophia Wang. We're thrilled to have Dr. Wang here to present this very timely and important topic, which also addresses the impact that this condition has on caregivers too, with caregiving being a very central part of CICOA's mission. Dr. Wang is a board-certified geriatric psychiatrist with extensive training and expertise in both clinical and research applications of medicine, and she's a Hartford Just Award recipient for future leaders in psychiatry. When I asked Dr. Wang if she could just share her expertise at our next lecture, she immediately agreed without hesitation. So we're very appreciative of her support for this lecture, as well as all the current and future collaborations between Dr. Wang and her team at Indiana Alzheimer's Disease Center. There's going to be a little bit of time for questions at the end, so if you have any questions, you'll have the opportunity to submit those throughout the lecture, and then we'll try to get as many answered as we can during the question and answer session at the end. So with that said, it's my honor and pleasure to introduce Dr. Sophia Wang.
Good morning, everyone. I would like to welcome all of you to today's CICOA Envision lecture titled Surviving COVID-19, Long-Term Cognitive and Mental Health Effects on Patients and Their Caregivers. I am Dr. Sophia Wang, and I'm a board-certified geriatric psychiatrist and an assistant professor of clinical psychiatry at the Indiana University School of Medicine. I also serve as the Outreach and Recruitment Core Leader at the NIA-designated Indiana Alzheimer's Disease Research Center. Before I get into my lecture, I would like to spend a few minutes to tell you how I became interested in this topic. Originally, I started my research career studying risk factors for Alzheimer's disease and noticed that my patients who were hospitalized appeared to decline cognitively and often reported feeling depressed. When I came to Indiana University, I started to collaborate with Dr. Barbara Kahn, an intensivist, to study how ICU hospitalization affected patients and their caregivers. And I will be sharing some of the results of our work today at the end of the talk. I do not have any conflicts of interest. So first, we'll briefly review what COVID-19 is and its epidemiology. Then we'll go over the neurologic symptoms that can be seen in those infected with COVID-19. Finally, the bulk of our talk will focus on discussing the long-term consequences of ICU hospitalization seen in many patients, also known as post-intensive care syndrome, PICS, as well as the impact of ICU hospitalization on their family members and caregivers, also known as post-intensive care syndrome family, or PICS-F. So COVID-19 belongs to a family of viruses known as the coronaviruses. Coronaviruses get their name from the Latin word corona, which means crown. That's named after the spiky appearance of the virus. For those of you who remember the SARS virus outbreak in 2003, COVID-19 belongs to this family of viruses as well. Of note, one of the most common questions I get is why we cannot take an antibiotic to kill off COVID-19. And the reason we cannot do that is because viruses are not living, and they require a living host to transmit them. So essentially, the COVID-19 has to hijack living cells of a newly infected host. And although we're still learning about the transmission of COVID-19, it appears to be mainly through aerosol transmission. So I also want to briefly touch on the biology of COVID-19. So this is an infectious genetic material that's wrapped in a gray envelope. And here in this diagram, you can see that the orange blobs represent membrane proteins, which serve as identifiers to let us know this is a COVID-19. And the yellow blobs represent the proteins needed for the virus to be replicated and released in the host bodies. And finally, the distinctive red spikes here allow the virus to enter the host body. So this slide shows the epidemiology of the COVID-19 deaths in Indiana from a couple of weeks ago. As you can see, the majority of deaths are those who are 65 and over, and especially those who are 80 and over. Also, African Americans are disproportionately affected. So taken together, this suggests that many of those who are surviving the COVID-19 infection are younger people. Although most of us think about COVID-19 as a respiratory disease, it does affect multiple organs, including the brain. Two of the neurologic symptoms of COVID-19 described by the CDC includes headache and the loss of smell. Furthermore, a growing number of studies suggest that the neurologic symptoms of COVID-19 includes encephalopathies, changes in olfactory and gustatory sensation, acute stroke, and then finally these infectious toxic encephalopathies. And those are often due to organ failure, metabolic disturbances, hypoxia, and general inflammation throughout the body. So headache is probably one of the most common initial complaints in patients who are infected with COVID-19. We'd say about the prevalence is about a third of patients are affected, and although we still don't know what the mechanisms are, we do think it involves somehow inflammation in the brain. And another common symptom is anosmia, or the loss of smell. And it has been reported in some cases as the only symptom. So as many of you know, the sense of smell is due to the olfactory nerve, which is essentially an extension of the brain. So although certain viruses are known to attack brain cells, it appears for now, and again, this is still under a law study, that the loss of sense of smell from COVID-19 may actually due to the virus attacking the cells which support the functioning of the brain cells rather than the brain cells itself. And as you know, another symptom that has been described for COVID-19 infection is loss of taste. We really don't know what causes that, but we do know that the tongue plays an important role in distinguishing between sweet, salty, bitter, sour, and umami. And we do know a number of other mechanisms through which loss of sense of taste can occur, but once again, we're still trying to investigate why COVID-19 is able to do it. So probably one of the most concerning neurologic symptoms related to COVID-19 is the impaired consciousness. That affects about 37% of hospitalized patients. There's been a number of causes that have been linked to impaired consciousness, and those could include infection, hypoxia, that is, insufficient oxygen, toxic metabolic encephalopathy, so that is essentially changes in the body's like sodium and potassium and other key elements, and then seizures. And then it's still an area of investigation, but there's been a number of informal reports about patients who continue to have impaired consciousness even after extubation. This is going to need to be studied further. So other studies are also starting to recognize that stroke, particularly in those who have severe COVID-19 symptoms, are more probably affect about 5% of them. So the mechanisms, again, are not fully understood, but it's thought to be a combination of inflammation as well as maybe COVID-19 causing changes in the blood to result in abnormal thickening and eventually clots. And these strokes come in all types. They can include acute ischemic stroke. It can infect the veins in the brain, so that's cerebral sinus venous thrombosis, as well as just outright brain bleeds, so intracerebral hemorrhage. Interestingly, people under 50 can also develop strokes as well. This does not appear to be entirely just restricted to older people. So this slide nicely summarizes the neurologic implications of COVID-19 and the mechanisms behind them. So on the left here, we have the non-immunological mechanisms, such as high blood pressure, decreased oxygen due to impaired lung capacity, and then clots due to changes in the blood. And then here on the right, we have changes in the immune system, and that can include damage to the adaptive immune system, basically causing the body to attack itself. The adaptive immune system normally functions as the body's response to infection. So here's where it's gone a bit awry. Another immunological complication from COVID-19 is activation of brain immune cells called microglia. So these are our brain immune cells that are specific to this organ. They don't occur in the rest of the body. And then finally, there can be an abnormal inflammatory reaction, which we would call the cytokine storm. Now, while normally the immune cell protects our body, it does appear that in certain vulnerable individuals, COVID-19 can somehow cause the immune system to go into overdrive, which is at least partly contributing to the neurologic symptoms that we see. And now it also appears that non-immunological and immunological mechanisms can lead to what we would call a septic or infectious encephalopathy, or simply delirium. So I'm going to go into what delirium is in a bit, but I wanted to bring special attention to the concept of delirium, because this is going to be a key part of our story as we try to understand the long-term symptoms that ICU survivors suffer from. So as many of you have heard on the news, COVID-19 infections were associated with an increased number of critically ill patients. These patients needed intubation, that is, they needed a breathing tube inserted to help keep their lungs going, and that in turn required them to be hospitalized in a special type of unit known as the intensive care unit, also called an ICU. And as many of you know, ICUs provide dedicated care, usually a nurse taking care of anywhere from 1 to 2 patients who are very, very sick. And they often also require a team of subspecialists to handle these very sick patients who are also familiar with a number of procedures. And here are the statistics for COVID-19 hospitalization in Indiana as of June 6, 2020. As you can see, there were over 1,000 ICU hospitalizations, 3.6% of which were COVID-19 related. And a significant proportion of these critically ill patients who were in the ICU had a number of comorbidities here, including cardiovascular comorbidities such as high blood pressure and diabetes, lung comorbidities such as chronic obstructive pulmonary disease, and then kidneys as well. So before COVID-19, there was a growing recognition that the quality of critical care has really improved over the past several decades. And as a consequence, death rates went down. And then conversely, as our population continued to age, based on what we at least saw prior to COVID-19, that an increasing proportion of ICU patients now became older. And as the ICU patients have become older, we've also seen an increasing number of patients who have developed what we call delirium. And we're going to discuss what the long-term consequences are of this higher rate of delirium. So just to take a moment, we do estimate that it's probably over 70% of older people hospitalized in the ICU that develop delirium. So even before COVID-19, there was some publicity given to ICU survivorship. But I think with the recent headlines from COVID-19, there's been a lot of news from major media outlets such as the Wall Street Journal and the National Public Radio, and these have brought much needed attention to this pressing issue of ICU recovery, which will be the focus for the rest of our talk. So post-intensive care syndrome, more commonly known as PICS, affects both the patient and the family members. And for the patient, this includes a constellation of symptoms, which are psychological, cognitive, and physical. And all of these symptoms can decrease the quality of life for the patient. We're going to go into risk factors that can predispose towards PICS, but probably the biggest one worth remembering is delirium, which I mentioned earlier was a common neurologic symptom seen in COVID-19. So I want to take a few minutes to make sure all of us are familiar with the formal criteria for delirium as described in DSM-5. In brief, delirium requires a disturbance in either attention or awareness. Generally, this disturbance is an acute change in mental status that develops over hours to a few days and fluctuates in its severity during the course of the day. There also needs to be an additional disturbance in cognition, such as a memory deficit, disorientation, language, visual spatial ability, or perception. The other key concept is that these cognitive changes cannot be better explained by another neurocognitive disorder, such as a dementia. And we also cannot diagnose delirium if somebody's having a coma. That is when essentially someone has a severely reduced level of arousal, such as most commonly when someone has a tube down their throat and is being sedated extensively to make sure that they keep that tube in. So although it's a topic for another time, distinguishing delirium from dementia, especially in patients who have pre-existing dementia, can be very challenging. And the key to successfully diagnosing delirium in these patients is to talk to family members to get more details about what their cognitive baseline was before hospitalization and whether that their patterns of thinking and behavior have changed since they've come into the hospital. Finally, there needs to be evidence from history, physical examination, or laboratory values that these changes are due to a medical condition, substance use, exposure to a drug or toxin, or multiple etiologies. So I want to emphasize that it is very common for many complex patients, including those who are hospitalized in the ICU or are older, to have multiple causes for them to develop delirium. So how does delirium affect the brain? First, an acute medical event such as an infection or undergoing surgery causes an inflammatory reaction in the rest of the body. Now, these inflammatory molecules can cross the blood-brain barrier to then cause inflammation in the brain. So you can see here that the inflammation in the brain is due to two types of special brain cells. The first one is known as microglia, okay? And the other type of brain cell that participates in the inflammatory reaction is known as astrocytes. And astrocytes are very important for supporting brain function. Okay, so this brain inflammation reaction then eventually has a number of effects. It then releases a number of inflammatory molecules within the brain that causes disconnection, within the brain, okay? And then it also leads to the inability to conduct electrical signals in the brain that are vital for brain functioning. And finally, it causes changes in various chemicals throughout the brain that are important to keep the brain going. And all these changes together results in the symptoms of delirium that we see. Again, including confusion, inability to pay attention, and fluctuation in cognitive status. All right, so now two of the most well-known risk factors for delirium are aging and dementia. And one reason that these may, contribute to the risk of dementia is because they cause the breakdown of this protective bubble around the brain, known as the blood-brain barrier, or BBB. Okay, so when this barrier becomes, quote, leaky, okay, with age and dementia, then these inflammatory molecules from the rest of the body can then get into the brain more easily, and again trigger this inflammation within the brain, and then again leading to delirium. So there are other risk factors for delirium that can occur in ICU patients. These include organ dysfunction in the heart, lung, liver, and the digestive system. And although delirium is known to lead to long-term cognitive impairment, many hospitalized patients, including those who are older and in the ICU, we don't really quite understand how this happens. What we do think is that somehow the brain inflammation or somehow a lack of oxygen may cause brain damage and therefore cognitive difficulties. But there's been a couple of other recent studies that suggest that there are other mechanisms still at play that we don't even know about yet. So how common is cognitive dysfunction in ICU survivors? It's pretty significant. Studies have shown anywhere from a 30 to 80% prevalence. And while a wide range of impairments have been documented, including difficulties with memory and attention, probably the most common one is executive dysfunction. And executive dysfunction really can have a profound impact on survivors' lives. So what is executive dysfunction? Well, most people commonly will describe it, say if they're doing work that they can't process information as quickly, they can't multitask, they say their brain feels foggy, they say they feel slowed. They may be able to complete the task, but it may take them much longer, like twice as long as it used to. And this kind of change can often lead to frustration, even depression. We see this especially again in younger people who are trying to return back to work and have very cognitively demanding jobs. And while many people's cognitive problems do improve over the first year, deficits, even in those who are younger and were cognitively normal before hospitalization, can persist many years later. So what causes executive dysfunction? Well, one thing that we know is that it appears that somehow delirium and ICU hospitalization affects a number of parts of the brain, but most particularly the frontal lobe, which is highlighted in gray here. There's a number of important regions, but the ones I wish to point out are the dorsolateral prefrontal cortex, highlighted here in orange, the orbital frontal cortex, highlighted here in green, and then the anterior cingulate cortex, which is highlighted here in this blue-gray color. And the dorsolateral prefrontal cortex is important for the execution of these higher level cognitive skills, which we often feel make us, special as human beings. That is, they can plan and execute complex new temporal structures of behavior, speech, and logical reasoning. Meanwhile, the orbital frontal cortex is involved in processing senses, such as taste and olfaction. That also regulates the internal environment, controls drives, and emotional behavior. And then the anterior cingulate cortex is thought to be important for cognitive processing, specifically reward-based decision-making and motivation. So one of the challenges with ICU survivors who are suffering from frontal lobe dysfunction is that many of the screening tests given in the primary care doctor's office, such as the mini mental state exam or MMSE, or the Montreal Cognitive Assessment, more commonly known as the MOCA, they don't often capture these frontal lobe deficits. So younger folks, especially people who are highly educated, they can score normally on these screening tests, especially if their only problem is executive dysfunction. And what really is key to accurately diagnosing these types of cognitive changes is careful history taking, specifically probing for these types of deficits. And then that has to be followed through objective documentation and administration of much longer cognitive screening. Can take up to an hour or even often 4 to 6 hours, especially again in younger people or people who are highly educated. So it's not uncommon for many people with frontal lobe deficits to be incorrectly told that their problems are in their head. They can be misdiagnosed with other problems or even go undiagnosed for long periods of time. So mental health symptoms are also common in ICU survivors. And those can include depression, anxiety, and post-traumatic stress disorder. The median prevalence of depression is about 28%, and people with pre-existing mental health disorders appear to be at higher risk for being hospitalized in the ICU. So there may be a bi-directional relationship that needs further exploration. Female gender, younger age, and lower education levels are also associated with higher risk of having mental health symptoms after ICU hospitalization. So now that we've talked about the effects of post-intensive care syndrome on the patient, I want to go now to talking about the effects on families and caregivers. So post-intensive care syndrome family, often abbreviated as PICS-F, describes the constellation of psychological symptoms that affect family members of a patient currently or recently hospitalized in the ICU. And we can see here in this table that the prevalence of PICS-F symptoms can be quite high. Depression is thought to affect as many as 70 to 90% of family members during the ICU stay. And likewise, anxiety affects anywhere from about 42 to 80%, again, of family members during the ICU stay. And then PTSD affects about a third. Now, it appears that the depressive symptoms do improve substantially by 6 months, and as well as the anxiety symptoms. However, post-traumatic or stress disorder, you can't diagnose that within a month, so you have to wait at least a month. Those symptoms appear to persist even 3 to 6 months afterwards. So caregivers, especially of ICU survivors, encounter a number of unique challenges, and that includes the lack of training and financial compensation for doing caregiver duties. Also, a lot of these caregivers are overwhelmed by having to provide support for new impairments, especially in older adults, and now they have to take over paying the bills, managing medication regimens, which are quite complicated, and providing transportation, as well as support throughout all these doctor visits. Also, for many caregivers, the loss of income due to the extent of just having to provide so much care for these frail ICU survivors can be quite significant, and often, especially patients themselves, are unable to work. So that really doubles the loss. Assessing caregivers for PICS-F is crucial, and the assessment should include questions about their sense of control of the situation, their perception of their support network, as well as the effects of caregiving on their own lives. Other key components for the assessment should also include how well they're taking care of themselves and whether they've been provided appropriate education and training for the patient's needs. So what can we do to address these really high rates of mental health symptoms in family members and caregivers? Well, there's been a number of interventions that have been tested to prevent and manage PICS-F while patients are hospitalized. There's a bundle of care for ICU management, which is known as the ABDCEF. I don't want to go into the whole bundle at this time, but I just want to focus on F. And briefly, F stands for family. So that is telling ICU providers to involve families in the patient's ICU care. Potential ways to do this include having open ICUs in which families are allowed to visit at any hour, as opposed to closed ICUs which have scheduled visiting hours. Another way to involve families in ICU care is, when appropriate, for healthcare providers to perform tasks in front of family members so they understand what is happening to the patient and why. And then finally, ICU diaries is another important tool that has shown mental health benefits for both patients and their family members. Essentially, members of the ICU team will put in various notes about the patient's progress and major events. Family members are also encouraged to write their observations and share pictures. And this tool can be really helpful for patients who forgot what happened to them and frequently do not understand when they are able to recover and they're back at home or in rehab, why their bodies have changed so much. And it can also be helpful in patients who have been delirious and may have altered perceptions about actual medical events, such as an invasive procedure performed on them. Whenever possible, ICU members should also try to engage family members in patients' care, such as inviting them to participate in rounds or provide activities for them to do with patients, such as swabbing their mouth to prevent them from drying out. Finally, education throughout the entire hospitalization upon ICU discharge will be crucial to helping family members adjust to the situation at home, understand their caregiver burden, and what to expect in terms of improvement for their loved one. So many families find actually that the loss of ICU structure can be especially challenging. So making sure families are given appropriate home health services, as well as web-based tools to understand what PICS are is really crucial. So you can check out this website through the Society of Critical Care Medicine. There's also another website called Health Talk that's available from the UK. And in some cases, referrals to mental health treatment for caregivers may be necessary to address severe depression, anxiety, and trauma-related symptoms, especially if caregivers are not able to fulfill basic responsibilities for the patients. And there needs to be a really strong emphasis placed on self-care to ensure they maintain or improve their mental health. And examples of self-care can include relaxation training and making sure they get regular respite to take scheduled breaks. So for more information about PICS-F, you can read our article that's freely available through the American Journal of Geriatric Psychiatry. So now that I've summarized the cognitive and psychological effects in ICU survivors and the impact of ICU hospitalization on the mental health of their caregivers, the question now becomes, how can we rapidly translate the information that we know about how to address all these concerns into practice? So in the last part of my talk, I'm going to discuss a model of care that has been created for ICU survivors, known as the Critical Care Recovery Center, or the CCRC. And the CCRC is based at Eskenazi Hospital in Indianapolis and is directed by my mentor and intensivist, Dr. Barbara Kahn. So in brief, the CCRC sees patients who've been admitted to one of the local ICUs and have either been mechanically ventilated and or delirious for 48 hours. And the hallmark of the CCRC is the recovery care coordinator. And this coordinator is usually a social worker or a nurse. And what they do is they spearhead the complex process of bringing together the many pieces of post-hospital care that ICU survivors and their caregivers need. And unlike many models of care, there is a focus both on the patient and the caregiver. Furthermore, the recovery care coordinator provides ongoing feedback during the clinical assessments to an interdisciplinary team. So in the CCRC, patients participate in a detailed history and physical exam, psychological assessment, and complete a cognitive assessment known as the R-bands, which itself lasts about 45 minutes to an hour. Caregivers also answer a questionnaire known as the Healthy Aging Brain Monitor. I'll go into that in a few minutes. But the patients and the family members then come back for a second visit. And during that second visit, the entire team provides feedback to both the patients and the caregivers about the patient's diagnoses, the individualized care plan, and if needed, appropriate care and support for the caregivers as well. And then they get set up with this care, and then they can get followed as needed in the CCRC and other appropriate subspecialty clinics. So I mentioned the Healthy Aging Brain Monitor, and I know it's a little difficult to read these questions, but basically I just want to give you an idea of what we do in the clinic. So essentially, you can see these columns here, and those columns represents ratings of 0, 1, 2, or 3. And then here listed are the various symptoms that they ask about. The ones in pink list all the cognitive symptoms, the one in yellow lists the functional symptoms, and the ones in green list the psychological symptoms. And then they rate each of these as 0 being not at all over the past 2 weeks, 1 being 2 to 6 days over the past 2 weeks, 2 being 7 to 11 days, and then 3 pretty much almost daily, 2 to 14 days of having the symptoms over the past 2 weeks. And then you can add these all up, and essentially higher scores mean higher levels of impairment, and then you can calculate for each of these subscales what their scores are, and then add each of these cognitive, functional, and psychological subscales to come up with a total score. It's a pretty easy questionnaire to administer. It can be done in about 10 minutes, and the caregivers can complete this in person, over the phone, or online, and it can give fairly readily a snapshot of how much symptoms the patient is having. And the nice thing about it is that it requires pretty much no training, so it can be used in any setting, including that of primary care doctors who are quite busy. So when compared to a cohort of primary care patients, we found that patients who were seeing the CCRC had greater difficulty with their cognitive, their psychological, functional, and total burden of symptomatology. We also showed that receiving care at the CCRC improved cognitive and functional symptoms, but not psychological symptoms. Total score also went down as well. So this led to the question, why didn't the CCRC's patient's psychological symptoms not improve? So we first examined the rates of depression in 204 CCRC patients, and then categorized them by their antidepressant use. And what we found was that nearly 1/3 of ICU survivors were already on at least one antidepressant their first visit to the CCRC. But over half of those ICU survivors who were on an antidepressant were not responding to treatment. And interestingly, African Americans were 4 times more likely not to be responding to antidepressant treatment and still having significant depressive symptoms. And given that about a little less than half of our CCRC patients were African American, this does reflect a racial disparity that needs to be examined further. So another common reason, for lack of antidepressant responses, psychiatric comorbidity. So we decided to then look at, psychiatric comorbidities in a subset of CCRC patients. So we categorized patients with psychiatric comorbidities based on how they responded to symptom screens for depression, anxiety, and post-traumatic stress disorder. Patients who were positive on all of these three screens were labeled as having a high number of psychiatric comorbidities, and those who were positive on only 1 to 2 screens were labeled as having low to moderate number of psychiatric comorbidities. And people who were negative on all those screens were labeled as having no psychiatric comorbidities. We also then asked the same participants to respond to a questionnaire about their quality of life. Higher scores, matching up with a higher quality of life. And so what we see here in this graph is that these are the three categories: none, low to moderate, and high psychiatric comorbidities. And then on the vertical axis, the quality of life measure. So again, higher is better. And what we found, not surprisingly, is that more psychiatric symptomatology correlates with a poorer quality of life. So that is, the people who are high have lower quality of life compared to those who had no or low to moderate psychiatric comorbidities. We also found that 31% of ICU survivors were in the high psychiatric comorbidity group. Therefore, we began to speculate that high rates of psychiatric comorbidities may be one possible reason that we did not see improvement in mental health symptoms just by being seen in the CCRC. So another major psychiatric symptom that many ICU survivors complain about is sleep disturbances. And so then we also decided to look at the relationship between trauma-related symptoms and moderate to severe depressive symptoms and the relationship with sleep disturbances. And what we found is that those people who had both trauma and depressive symptoms were more than 16 times more likely to have sleep disturbances compared to those who didn't have any trauma or depression symptoms and had no history of depression. It seems that trauma-related symptoms and no depression history did increase sleep disturbances by more than fourfold. However, there did not appear to be a relationship between depression and sleep disturbances in the CCRC patients. So again, this begins to suggest that psychiatric comorbidities do correlate with severity of symptomatology, at least for sleep. So in summary, COVID-19 has a number of unique neurological manifestations, including delirium. These COVID-19 patients who are experiencing delirium may be at higher risk to experience prolonged cognitive, psychological, and functional impairments, which is known as post-intensive care syndrome and PICS. Prolonged post-intensive care syndrome can also cause significant mental health distress in family members, and again, that is known as PICS-F. So finally, a model of care focused on ICU survivors and caregivers may provide benefits for cognition and functioning, but and ongoing trials are needed to verify these initial findings. So we will share those once they become available. However, it does appear based on our initial analyses that the mental health symptoms in ICU survivors, the picture is complicated by the fact that there are pre-existing mental health conditions and a fair amount of psychiatric comorbidities. So I wish to thank all of my mentors, particularly my ICU survivor mentor, Dr. Barbara Kahn. And I also want to give a special thanks to all of the CCRC patients, caregivers, and staff for making this research possible. Also want to thank a number of funding agencies that have supported my work along the way, including the Indiana CTSI, the NIA-funded 2016 Delirium Bootcamp, and particularly the NIA for funding my Career Development Award that is related to this work, and for my effort at the Indiana Alzheimer's Disease Research Center. I would also like to take a moment to say a few words about the Indiana Alzheimer's Disease Research Center. We are one of 32 centers which focus on Alzheimer's disease and brain health, and are funded by the National Institute on Aging, which is a division of the National Institutes of Health. Our mission is to provide the most up-to-date information and research about Alzheimer's disease and brain health to everybody, whether you're just healthy and just want to learn more about how to keep your brain in great shape, or whether you're a patient, family member, or healthcare professional. As part of our taxpayer-funded work, we are happy to provide talks to all interested groups free of cost and no matter where you are. So please learn more about our center and check out our other talks by going to our Facebook page or website. You can also reach us through email or phone and learn how you can join our fight against Alzheimer's disease and keep your brain healthy. And most importantly, feel free to contact us with your questions, ideas, or topics that you would like to see us give future talks on. So I want to thank you again for coming to today's talk. If you have any questions, you can stay for the question and answer session afterwards, or you can feel free to email or call me, and I hope to see you at another talk soon.
Thank you, Dr. Wang. That was great. Thank you for all your work, as well as such innovative and quick information for such a novel and still new disease that we're dealing with here, not just in Indiana, but globally. So thank you again for all your great work. I love the perspective of the caregiver when it comes to this too. I think it really shows, which is also CICOA's approach, the importance of a dyad caregiver approach. These things are really at least a two-person condition, right? I mean, when these patients get home, hopefully when they get back home, they have the caregiver support that they need to optimize their health and maintain their wellness. But, you know, what about the caregiver and their needs and the impact that it has on the health outcomes? So thank you very much for that important information on caregivers and tying those two together. We've got a couple of questions for you. And I think I'll start with the first one. And that's when it comes to, you mentioned the blood-brain barrier, and how it's, in this circumstance, when it comes to delirium, people may have an inflammation getting in and kind of breaking down to allow for those conditions to occur. Is the blood-brain barrier biologically something that kind of declines over the years with natural biological aging, just like other components of the human body when it comes to the aging process?
Hi, Dustin, it's Sophia. Thank you so much for having me today. So yes, in brief, we do know that there are changes to the blood-brain barrier for aging. Just to make sure we're on the same page, the blood-brain barrier is essentially, as I mentioned, this protective bubble. And what it does is that it acts as a gatekeeper to make sure that certain items which are not safe for the brain can't enter. And that's really great that someone asked, like, does this change with age? Because we do know that obviously as people are older, when they get infections, even if they're cognitively normal, they might seem a little more confused or more easily fatigued, and that's the result of the blood-brain barrier. It has a converse effect, though, because one of the reasons that we think we were having trouble developing successful drugs for Alzheimer's disease is that the blood-brain barrier is preventing those drugs from getting into the brain effectively. And so part of our work is looking at brain scans to try to make sure that there's penetration
they have to have special drug delivery systems. So the blood-brain barrier is very physiologically an important barrier for our body, but at the same time, when we start to have disease processes, makes it very challenging. And we obviously know that dementia and other Parkinson's disease and stroke can also damage the blood-brain barrier. So that's a really good question. I appreciate that.
Okay. Thank you. Thank you. With the CCRC model at Eskenazi, is that unique to Eskenazi Health? Is that a model that is kind of proprietary to you, and could it be replicated?
So that's another great question. So the ICU Survivor Clinic model is actually rapidly spreading. The critical care recovery center directed by Dr. Barbara Khan was the first one set up here in this country. It's actually been a model used quite a bit in Europe, but had not really started until several years ago with Dr. Barbara Khan. The second one was then developed at Vanderbilt by Dr. Wes Ely. And now there's a number of these across the country. It's not highly standardized, though, in terms of the types of care that they have, that they offer the services. One of the clinical trial studies that we are doing, though, because I mentioned that's in the process of being validated, is that they're randomizing to show that the type of care being provided, there's something very specific about providing both patient and caregiver support. I believe they're also developing, for those who are interested in the local resources, developing another ICU. I think there is another ICU survivor clinic at IU Methodist. And if people are interested in getting their patients engaged into those services, please contact me. We're more than happy to help your patients get connected to that type of care, because it is something we're very fortunate to have, at least in the Indianapolis area. And they do provide, especially now because so many things are now with COVID-19, we definitely work with folks around the state. So that's another really wonderful question. I appreciate that.
Cool, very good. Yeah, good to have that here locally. Of course, Europe always seems to have the upper edge on some things with us. So
it depends on what it is, but I think I think when it comes to models of care, I think they really have put a lot more thought into it. I think one challenge that our system has compared to the European models is that as we're seeing now with COVID-19, a little bit more, things tend to operate a little more independently, whereas in Europe, they're much more integrated, and the government has a much greater, I think, investment because there's so much government payment directly to make sure that there's coordination of care. And so what a fair amount of these ICU survivor clinics try to do is they try to coordinate all these different appointments, because a lot of people have 10, 11 subspecialists, which can easily happen after an ICU stay. And that can be very overwhelming to both the patient and caregivers, just to try to even get all these doctors to talk to each other. And as you know, some people split their care across systems. That makes it even more challenging. And that's where these ICU survivor clinics, that's why the recovery care coordinator, one of their key jobs is just to get all these specialists to talk to each other, because it's a tough job.
Yeah, absolutely. Just navigating it during an already challenging time, and all those factors, our favorite term, the social determinants of health, how that plays a role into post-discharge and making sure that those patients hopefully stay out of the hospital system for as long as possible.
Right. And that's and that's the reason that Europe actually has a vested interest, because the rehospitalization rates are very high, like 50 to 70%, depending on the baseline clinical characteristics. So.
Okay, for COVID specifically?
No, for all ICU patients, broadly.
Oh, okay.
Yeah. So that's why this is, so the rates of rehospitalization amongst ICU patients is very high. So that's one of the reasons I think the Europeans started to build those models of care. So, and why we also became invested as well in that. So.
Sure. So what percentage, so we saw the numbers of Hoosiers as of early June, I believe it was, that have been in the ICU with COVID-related symptoms. What's the average length of stay, would you say, in the ICU for COVID specific?
I don't have that information off the top of my head. I can probably touch base and get some folks there. I think it varies, but it's certainly on the longer end if they require extensive intubation. We certainly hear that it's, closer to weeks, and we've had people who've been there for months. A phenomena that's not well understood, but that's beginning to be observed, is that even after people are extubated, they seem to have a very lengthy period in which before they become completely interactive and conscious. We're talking like days. And that's a new phenomenon. We don't fully understand it. So right now we do have numbers, but they're not very accurate, because some people are still in the hospital, because some people are staying there for months. So it does seem that there's a trend towards COVID-19, a longer length of stay, but this is something that we probably need to wait a little longer to get more longitudinal data on. But I can certainly get the more precise numbers. Obviously, younger people have much shorter stays. So the problem is that the data is a little skewed right now. It's either people who unfortunately passed away pretty quickly because, extubation, they extubated and didn't make it, or people who are much healthier. So what we'll probably see realistically is a bimodal distribution. I think the other complicating factor is, good complicating factor is that we are trying to find some drugs that ameliorate these symptoms. So dexamethasone, for example, remdesivir. So we're also probably, hopefully, going to see a drop in some of these lengths of stays when people have severe symptoms. So this is kind of an evolving picture where I can certainly go capture that and get back to you.
Yeah. It's amazing just the information that we have already, that we've obtained in just this short amount of time with this novel virus. Kind of to a similar question with the older adult patient population, do you see most of them being discharged home, or do you see a lot of them going, if they weren't in an extended care facility first, do you see them going back home upon discharge, or do a lot of them end up going to an LTC for at least a certain amount of time?
Yeah, another really great question. So statistically speaking, before pre-COVID-19, if an older patient got hospitalized in the ICU, they almost were guaranteed the probability was extremely high. If they were, especially if they were intubated and were delirious, they would end up in subacute rehab. So basically getting physical rehabilitation in a nursing home, or ending up needing nursing home place. And not everybody, but they would go through a period of transition of care. And a lot of them would end up home. Now it's extremely more complicated because of COVID-19. Hear of a lot of family members very anxious about having their loved ones stay away from them longer because of the COVID-19 restrictions, so people refusing that. I think probably if we didn't have some of these complicating psychosocial factors, just statistically speaking, yes, more older patients we know are just already frailer going into the ICU, and definitely much longer to recover. So under, and a lot of it geographically depends, but yes, probably they will need a lot more transitions of care before they can end up home. So, and I think we're still beginning just to understand. This is just the beginning of what I think will be a long story. So,
yeah, very good.
All right.
Well, I want to be respectful of everybody's time, but we still got quite a number of participants, so I'm sorry I couldn't get to everybody's question.
No, that's okay. And if people want, they can email me the questions. We're happy to answer them. I saw a lot of really great questions. So if you didn't see a question answered, just send us an email and we will answer them. Give us a week because of the holiday. Normally I say 48 to 72 hours, but we're heading into a major holiday weekend. So we're more than happy to answer all of your really wonderful questions and get back to you. So.
Well, thank you so much, Dr. Wang, for this and everything that you do and all your work with the Aging, yes, and Alzheimer's Disease Research Center. And we look forward to our future collaborations. Thank you for being a part of our first one this year of our Vision Lecture Series. And our next one actually coming up again on Wednesday, September 23rd. One of your colleagues, Dr. Diane Healy, geriatrician with St. Vincent Medical Group, is going to talk about what we're kind of labeling as age-friendly health systems 2.0. So the updates on that and where we're going with that new model of care. So thank you again very much. Thanks to all of our attendees, and we look forward to seeing everybody next time.
Well, thank you, everyone, and don't hesitate to reach out if we can be of any further service. Take care and stay safe.
Thank you. Thanks, Dr. Wang.